Good afternoon to you all. I hope you're able to hear me.
Yes.
Yes, sir.
Okay, can you all see the screen?
Yes.
Okay, so today we are going to be looking at chronic infections. There are quite many, but we shall focus on a few most important ones that we think you need to know. And this is our outline today. We shall look at mycobacterial infections. We look at, now among these we have things like TB, things like leprosy. Those are the most important that we shall look at among the mycobacterial infections. Then we shall also look at spirochete infections. And here, our main focus is going to be syphilis. Then we shall look at schistosomiasis, not in much details, just a brief hint on schistosomiasis based on the different species of schistosoma. Now, the remaining three, you'll have to find time and read about them. But most important about malaria, please read about malaria. Know the different species of the malaria parasite and the life cycle. And then the presentation of the different types of malaria. The simple malaria versus the complicated. That is going to be an assignment that I think you'll have to hand in online. I'll talk about that more when I'm finishing. So let's go straight to this, tuberculosis. So the other name for tuberculosis is also known as Koch's disease. Koch is the scientist who discovered this disease first. Please, when you join, put off your microphone so that you don't interfere with the presentation. So tuberculosis, it's a very common communicable disease. that is caused by Mycobacterium tuberculosis. It's caused by mycobacteria. And this mycobacteria that causes tuberculosis is strictly anaerobic organism that only thrives when there is oxygen. And that's why we find it in areas which have a high oxygen tension, like in the apex of our lungs. That's where this organism usually stays, and it colonizes that place. Human beings are the reservoirs for this infection, so it moves from one human to another via aerosols, like we shall see in the subsequent PowerPoint. However, the mycobacterial organisms are quite many. There are different types of mycobacteria that can affect human beings, but the commonest is Mycobacteria tuberculosis hominis. It's not that usually causes disease in humans. But there are others which also cause disease, but not very common, like the Mycobacterium bovis. This one is acquired through ingesting contaminated milk and other dairy products. There's Mycobacterium capri, Mycobacterium africanum, microti, pinnipedi, and then Caneti. So those are the different mycobacterial species that can affect humans. But like I've said, Mycobacterium tuberculosis hominis is the most important for us today because it's what causes the disease among humans that we see commonly. So this organism is a rod-shaped, non-spore-forming organism that's weakly gram-positive, and it has a high concentration of mycolic acid in its cell wall that readily binds carboxyl. This is one of the stains that we use when we're detecting this organism. So that mycolic acid binds to carboxyl so strongly that when you try to decolorize it with acid alcohol, it will that decolorization, so it's going to retain the of the carboxyl. So because of that, we shall call it, they're also known as acid-fast what? Acid-fast bacilli, because of that property of tightly bind to mycolic acid and resisting decolorization by acid alcohol. So they're also known as acid-fast bacilli. This is the epidemiology of the disease. There are about 2 billion individuals who are infected with this tuberculosis worldwide. And every year we see about 8 to 10 million cases, new cases every year. And about 1.5 million people die every year because of tuberculosis. There are a number of risk factors, and these are the ones listed here. Poverty. So areas or countries that are really poor countries and people living in poverty, there's one that are at a high risk of getting tuberculosis. Then crowding, prisoners, you know that our prisoners are all crowded. So prisoners are at a high risk of getting what? Tuberculosis. Then people with chronic debilitating illnesses like diabetes, HIV/AIDS, malnutrition, Hodgkin's lymphoma, alcoholism, chronic renal failure. All these diseases cause some bit of immune suppression of some level. So they predispose you to acquiring this organism. So what is the etiology of TB? TB is transmitted by inhalation of aerosols, airborne aerosols. So if someone has TB and they're actively coughing, the moment they cough, they produce what we call aerosols. They're small, these microorganisms are in these particles which these are producing whenever they cough. Just like the same way we saw when COVID was coming, people were talking about droplets. So the same way TB is transmitted through those airborne droplets that are produced by people who are actively coughing and they are infected. So they produce those aerosols that now have to be inhaled by another susceptible host. The other is by exposure to contaminated secretions of infected individual. So if someone has TB and they're producing sputum, probably maybe they spit somewhere and then you come and touch into that sputum and you don't know. You can acquire TB that way. People who work in the labs, they're at high risk of what? Getting TB because of dealing with these secretions all the time. Then drinking contaminated milk. This one usually we see with the abdominal TB, and this is caused by Mycobacterium tuberculosis bovis. Mycobacterium bovis. There are other types of mycobacteria like what MAC, also known as Mycobacterium avium complex. This causes disease mostly in immune suppressed individuals. So now you need to know the pathogenesis of TB. And this is a stepwise process that you need to understand. It involves a number of cytokines and a number of other chemicals that the body secretes. But it's very important that you try to acquaint yourself with these different chemokines and cytokines. Because when you ask for the pathogenesis, we shall look out for those terms. They're the ones you want to see that you've written and you know what they do. So the pathogenesis is a stepwise process that starts with acquisition, with inhalation of the aerosols that go through the respiratory tract into your lungs. And once they reach the lungs, in the lungs you have what we call alveolar macrophages. They are the ones that act as what we call sentinel. They're like, okay, they're the immediate cells that react to these mycobacteria. So the macrophages, they are the ones that actually get infected first. And after they're infected, we shall see subsequent release of what we call T helper cell of type 1 that actually are responsible for causing the granulomatous inflammation that we see in tuberculosis. So the first step is into the macrophages, and this is facilitated by a number of receptors. They're what we call the mannose binding lectin and the type 3 complement receptors. They are the ones that recognize the mycobacterium. They recognize certain components on the cell of the mycobacterium, and then they ingest this mycobacterium. They phagocytose it. If you remember this, we looked at these things in acute inflammation, phagocytosis. So the macrophages phagocytose this mycobacterium. And when this mycobacterium reaches the macrophage inside, instead of being killed by the mechanisms that we saw in acute inflammation, by the peptidases, by the things like reactive oxygen radicals and all those things, the mycobacterium resist this microbicidal activity of macrophage by preventing the fusion of the phagosome, which contains that mycobacterium, and the lysosomes that contain these enzymes that would otherwise kill it. So it prevents that fusion. And because that fusion doesn't take place, the mycobacterium is now going to proliferate within the macrophage, unchecked by the immune system. So usually this one happens within the first 3 weeks of infection. And now the bacilli are going to proliferate within the alveolar macrophages in the air spaces. And after some time, these macrophages, they are going to be overwhelmed by the load of mycobacterium within them. So they are going to rupture. They're going to burst open, and they're going to release this mycobacterium into the circulation. So now they are going to move from the macrophages into the bloodstream. And when they reach the bloodstream, they are going to be taken to different sites. But the first site where they go are the hilar lymph nodes. The lymph nodes in the hilum, that space between the two lungs, we call the hilum. So the lymph nodes in that place are the ones that are going to receive this mycobacteria first from the lungs when the macrophages rupture and they release them. So usually within these first 3 weeks, most people are going to be asymptomatic, or they may present with a mild flu-like symptoms, some bit of fever, some bit of body weakness, some bit of feeling unwell, basically, non-specific symptoms that you may hardly recognize as TB. So after them being seeded, now when they reach the lymph nodes in the hilar region, this mycobacterium, there are certain antigens that those particles on the surface that were initially recognized by the macrophages, they are going to be processed into what we call they are the antigens that are recognized by the body. So they are going to be processed by the what we call the antigen presenting cells, and these are the macrophages and the dendritic cells, which are within the lymph nodes. So they recognize these antigens, they process them, and then they are presented to the CD4 T lymphocytes. Because now the macrophages have failed to deal with the mycobacterium. So what they do, they pass it over to the CD4 lymphocyte, to the CD4 T cells within the lymph nodes. And the macrophages also secrete what you call interleukin 12, which now acts on the CD4 T cells to which these antigens are presented. And then these CD4 T cells, they have now to differentiate into the active cells, what you call the T helper 1 subtype of the CD4 T cells. And now this T helper 1 type of the CD4 T cells are going to produce what you call interferon gamma. So after that, you are going to find so many cytokines that I'm going to talk about in this presentation. But it's important that you recognize which cytokine is secreted by which cell. Macrophages secrete interleukin 12 that acts on the CD4 T cells to make them differentiate into T helper 1 type. So after that, the T helper 1 type cells are going now to form the interferon gamma. Now, we are going to see what these CD4 T cells do. So once they have differentiated into the T helper 1 type, they are going to secrete interferon gamma. And interferon gamma is going to activate other macrophages within the lymph nodes, which again going to release a number of other mediators that are going to activate several other genes. So you think that now there's an interaction between the macrophages and the CD4, the T helper 1 type of cells. They're interacting. First of all, macrophages secrete interleukin 12. They act on the CD4 T cells to form the T helper 1 subtype of cells. Then the T helper 1 subtype are secreting interferon gamma that again activates more macrophages to release other mediators that are going to activate several genes. And among these genes, we have things like tumor necrotic factor, which is going to be secreted. And this one is responsible for now recruiting, calling in more monocytes. Remember, monocytes are in blood. When they enter the tissues, they become macrophages. So the tumor necrotic factor calls in monocytes to come to the site where these mycobacteria are. So these monocytes now are going to differentiate into what we call epithelioid histiocytes. The other gene that the other mediator that is going to be induced by the macrophages is what we call the inducible nitric oxide synthase. Now, this nitric oxide synthase is very important in that it helps in formation of nitric oxide. If you remember your lecture of acute inflammation, nitric oxide is one of those mediators, which is very important in killing off of some of these organisms. So nitric oxide is going to be secreted because of this enzyme, which is induced, the nitric oxide synthase. It's going to be induced. It's going to cause the secretion of nitric oxide, and this nitric oxide is very important in killing off of this mycobacterium. The other important enzyme or protein that is going to be secreted is what we call defensin. Remember, defensin is one of those enzymes that we talked about. Defensin. This one is also toxic to mycobacterium, and it's also going to help in the killing off of what? Of these mycobacteria. Then, after that, the T helper 1 cells are now going to orchestrate the formation of granulomas and caseous necrosis. They're going to drive the response. They're going to drive the formation of granulomas. How do they do that? They induce deactivated macrophages. Remember, tumor necrotic factor is going to recruit in more macrophages. So these activated macrophages are going to differentiate into epithelioid histiocytes that aggregate to form granulomas. And some of these histiocytes are going to fuse, and they're going to form what we call the Langhorne type giant cells, which we see in the TB. I'm sure you've covered granulomatous infections, and you know the components of a granuloma. One of them is necrosis. The other one is epithelioid macrophages. You may find giant cells. You may find fibroblasts. You may find other inflammatory cells like neutrophils, macrophages, eosinophils, plasma cells. All those are going to be there. So here we are seeing how these epithelioid histiocytes are going to come in and how giant cells are going to be formed by fusion of these macrophages. They fuse to form the giant cells. And we are saying that this response, the formation of the granuloma, will help in halting the infection. It will put a break, it will put a stop to the infection before significant tissue destruction has taken place, or before a serious illness occurs. However, in people who are immune suppressed, the infection progresses and the ongoing response is going to cause what we call caseous necrosis. So in people who are immune competent, you don't have any immune suppressive condition, this granulomatous infection is going to stop the progression of the tuberculosis. So you're likely going, it's likely going to stop somewhere there, and you not have an overt disease. But in people who are immune suppressed, they're going to have caseous necrosis, and this will progress to now overt TB infection, to overt TB disease. Remember, there are two things: having TB infection and TB the disease. There are two important things. You have TB the disease when you have the symptoms, but most of us are all infected. Actually, most of us are all infected with TB, but we don't have the active disease. So infection and disease are different things. So this is a pictomicrograph showing you the stepwise process of the pathogenesis of TB. From the mycobacterium here, which is recognized by the mannose and the complement receptor 3 on the macrophages. It enters the macrophage as a phagosome. Now, this phagosome inhibits the fusion of the phagosome with the lysosome. They don't fuse, so it continues to divide. As it divides, the macrophages rupture, you get bacteremia and seeding to the lymph nodes. When they go to the lymph nodes, the macrophage secrete interleukin 12, which acts on the T cells to form the T helper 1 type. The T helper 1 type also forms the interferon gamma, which acts on the macrophage. to secrete to induce other mediators like tumor necrotic factor, inducible nitric oxide synthase, and defensins. And those are going to give you now the final outcome, which is a granulomatous inflammation that we are seeing here. With these epithelioid histiocytes, the central necrosis, and some of these fused form giant cells. So this is this pathogenesis of TB. So what are the clinical so TB has got a number of clinical types. When you get tuberculosis, there's what you call primary and secondary TB. Now, primary TB is that TB that we see in people who have never been infected by this disease before. Like, it's the first time they're getting the disease. And it's usually acquired through the respiratory tract, usually. That's primary. Secondary TB is that TB which we see in people who have ever been infected, but they either get reactivated or they get another infection. So now this is when you need to get the difference between what you call TB infection and TB the disease. After that TB infection, I've told that most of us here are infected with TB, but we don't have the active disease. And that TB is lying somewhere in our lungs, usually in the middle of the lobes, either the lower part of the upper lobe or the upper part of the lower lobe. It lies there and it's basically controlled there by the granulomatous infection. But when you get immune suppressed, that TB can get activated, and then you can now present with the TB disease. So primary TB is a form of disease that developed in a previously unexposed, therefore unsensitized person. The source of the organism is always exogenous. It comes from outside. And most of the people, the infection is contained, but in others, it progresses to what we call primary progressive tuberculosis. And primary progressive TB will resemble any bacterial pneumonia in the lungs. So it will present with a consolidation of the lobe. Usually our lungs are like a sponge. They are spongy. The normal lungs are spongy. But when you get an infection, because of the edema that comes in, the fibrosis, they become hard. So we call that a consolidation. So it presents with a consolidation of the lobe that is infected. It presents with a hilar lymphadenopathy. So the lymph nodes in the hilum, they enlarge. So we call that hilar lymphadenopathy because it's affecting the lymph nodes in the hilum. That's why you call it hilar. Then it also causes a pleural effusion because of the inflammation, and there's that effusion that comes. Remember, effusions in acute inflammation. It's a form of acute inflammation, effusions. We can have a lymphatic and hematogenous dissemination of TB. So these organisms can enter the lymphatic drainage or the blood system, and they can be moved to other parts of the body. For example, they can go to the brain and you get what you call TB meningitis, or they can go to other body parts and you get what you call miliary tuberculosis. Now, miliary comes from the millet-like appearance of these organs when you harvest them after death. We shall see this when we look at miliary TB in detail. So that is primary TB. Secondary TB on the other side is what we see in a previously sensitized host. It may follow shortly after primary tuberculosis, but most commonly it appears months or years after the initial infection. And it appears usually when your immunity is broken down, when your immune system is weakened, that's when you get secondary TB. So it may follow a reactivation of a latent infection. So usually we have this TB in our lung somewhere, and it's silent, it's latent. It's just waiting for that chance. When you get immune suppressed, then it comes up. or it may follow an exogenous reinfection. So secondary TB usually affects the apex of the upper lobes, either on one side or both sides. That's why we commonly see secondary TB affecting. Remember, I told that primary TB usually affects the mid regions of the lung, either the lower part of the upper lobe or the upper part of the lower lobe. So it's in the middle. But secondary TB usually affects the apex of the lung lobes, either one side or both sides. And because of usually when you get infected, the body secretes antibodies and it forms memory of this infection. So in primary TB, when you get the first time infection, the body forms immunity. It forms antibodies. It forms memory cells against this infection. So when you get reinfected the second time, your body is going to easily recognize this infection. And because of the pre-existing already antibodies, the body is going to fight this infection so hard that it's going to cause marked tissue damage. So a lot of your tissues are going to be damaged in secondary TB. That's why we shall see that in secondary TB, we see a lot of fibrosis, a lot of cavitations in the lungs because of your body is already awakened to this infection. So you're going to cause a serious fight against it. So as a result, the regional lymph nodes are less prominently involved in early secondary disease than they are in primary TB, because they already have defense cells, so they don't get that much involved in secondary TB like we see in primary TB when you're just getting the disease for the first time. Understand that cavitations occur in secondary disease, secondary TB, and may erode into the airways, forming an important source of infection. So when you form these cavities, when these cavities are forming as the body is responding to the infection, the cavities may enlarge and may erode the airway. That's when you see people now coughing out very thick sputum that is looking like pus because of this caseous material that is eroded. The caseous material, which is at the center of the granuloma, now gets to drain into the bronchioles, and then someone coughs it out as that thick, purulent sputum. So, what is the morphology of primary TB? So, in morphology, we have what we call the gross morphology. What you see with your naked eye is what we call the gross morphology. So, primary TB usually affects the distal air spaces of the lower part of the upper lobe. This one I've already told you, or the upper part of the lower lobe, and it's usually close to the pleura. So it's at the periphery of the lung, near the pleura, and it's either in the upper part of the lower lobe or the lower part of the upper lobe. That is very important for you. Grossly, you can tell that this is primary TB when you see some of these things. And it forms a 1 to 1.5 area of gray-white inflammatory consolidation with the center of caseous necrosis. So this part where this primary TB usually settles will range from 1 to 1.5 centimeters in diameter, a consolidation of that size. And that's what you call a gone focus. Gone was that scientist who discovered this first. It's called a gone focus. Now, remember we said that these bacilli are going to drain to the hilar lymph nodes, and they're going to cause swelling of these lymph nodes in the hilum. So the tubercle bacilli are either free or within the macrophages. They travel via the lymphatic vessels to the regional lymph nodes, which often caseate. So they enlarge and also form caseous necrosis in the lymph node. Now, the combination of the parenchymal lesion, which is the gone focus, and the nodal lesion is what we call the goni complex. This is very important. Please get this. The combination of the parenchymal lesion, which is the gone focus, plus the nodal lesion is what we call the gone complex. So sometimes when this gone complex forms, it later undergoes fibrosis because of the normal healing. And as fibrosis takes place, there's going to be what we call calcification. I hope you studied the calcification. That is the type of calcification here that happens, what we call dystotic calcification, because it's happening in dead tissues. So calcification will take place. Now, when you do an X-ray of this person's lung, you are going to see a hyperdense lesion or a bright white lesion because of deposition of calcium. That is what we call a rank complex on the radiograph. These are all important facts that you must know. Because when you ask you for the morphology of primary TB, you expect to see the part of the lobe which is affected. We expect things like a gone focus, gone complex, rank complex. Right? So, microscopically, we are going to see granulomas, which are going to be both caseating and non-caseating. So the individual tubercles, the individual bacteria are microscopic, so you can't see them with your naked eye. But sometimes they can coalesce together and they can form macroscopically visible nodules. So the bacteria can either be seen microscopically or macroscopically when they coalesce. And these granulomas are going to be encircled by a rim of fibroblasts and lymphocytes. And you're going to see giant cells, what we call the Langhorne giant cells that we see in tuberculosis. So when you ask for the morphology of primary TB, please expect to see.
Excuse me, sir.
Yes, please.
It's like your voice is not coming out clearly. I don't know where the problem is coming from, and as if the problem is general.
It might be the issue of the microphone I'm using. Can I just take off the earphones and I try to? Is that clear?
Somehow.
Yeah, so I'll take off the earphones.
Okay, thank you, doctor.
Yeah, so I was saying that if we ask for the morphology of primary TB, we expect you to talk about the part of the lung that is affected. We expect to things like a gone focus, gone complex, rank complex as the gross morphology. Then microscopically, we expect to see things like granuloma formation, both caseous and non-caseating granulomas, which contain fibroblastic rim, lymphocytes, giant cells, things like that. Those are things we expect you to talk about. So these are the two micrographs showing you TB. Now, in A right here, we have this area where there's a red arrow. This red arrow is pointing to the gone focus, which is at the periphery of the lung, at the apex, at the top, at the upper part of the lower lobe, or the lower part of the upper lobe, just in the middle there. That's the gone focus. Now, this other one where there's a blue arrow is a nodal lesion. So the combination of these two is what you call the gone complex. And when you do an X-ray of the lungs and you find these lesions and they are calcified, we call that a rank complex. In B here, we have what we call now the microscopic morphology. This amorphous pink area right here at the lower left corner, this is caseous necrosis. This other part here which follows is fibrosis. There are spindle-shaped cells and other small, basically mixed inflammatory cells, lymphocytes, some histiocytes, and all that. Then there are cells you start to prefer, these large ones. These are Langhorne type of giant cells. Then at the periphery, we see lymphocytes and other cells. So this is what we see on the microscope. Then in secondary TB, we see the lesion as a sharply circumscribed consolidation, which is firm gray-white, usually at the apex of the lung. It's formed in the apex of the lung. And it has a variable amount of central caseous necrosis, peripheral fibrosis, and calcification. That's the morphology. So it's the same morphology: caseous necrosis, fibrosis, calcification. The other thing you shouldn't forget in secondary TB as the morphology is cavitation. This irregular cavity lined by caseous material. This is very case of secondary TB. Then, now, because of the fact that these cavities tend to be enlarging, these caseous areas, the TB keeps on eating up the lung. Sometimes it may erode into a blood vessel. And when it erodes into the blood vessel, that's when this people tend to present with hemoptysis, coughing of blood, because this TB has eroded into blood vessel. Then they start coughing up what? Blood, what you call hemoptysis. It's one of the clinical features of TB. Now, secondary TB has several morphological types. These are morphological types of secondary TB. When you ask for morphology of TB, please give these things I've talked about first. Consolidation in the apex of the lung, secondary TB. Consolidation in the apex of the lung, caseous granulomatous inflammation with caseous necrosis, fibrosis, and calcification. Then cavities are going to form. That's secondary TB. Remember, in primary TB, we had a lesion in the middle of the lung. We had a gone focus, a gone complex, a Ranke complex. The microscopic morphology is the same. Granulomatous inflammation, and you mentioned all the components of a granuloma, you get all the marks. When you ask for morphological forms of secondary TB, these are the ones. You can have miliary primary tuberculosis, which occurs when the organisms drain through the lymphatics and enter the venous circulation, and then they are brought back to the blood, to the lungs via the arterial system. So, in miliary primary TB, the organism enter via lymphatics, they enter the venous system, they join the arterial, and they circulate back to the lungs. And they are going, because the arteries permeate, or they form numerous branches that permeate the whole lung, you're going to see multiple small consolidations which are spread throughout the lung that on radiograph are going to appear like millet droplets. That's why it's called miliary primary tuberculosis. They appear like millet droplets in the lung. Then you can have systemic miliary tuberculosis. So this miliary tuberculosis that affects all the organs, like multiple systems. It can go to the kidneys, it can go to the lungs, it can go to the pancreas, it can go to the spleen, it can go to the brain, it can go to the liver, it can go to any organ. That is systemic miliary tuberculosis. Then there's what you call endobronchial or laryngeal tuberculosis. Now, this one develops by when these organs are spread through the lymphatic channels or from the expectorated infectious material. Remember, when you're trying to cough out, this infectious material has to pass through the larynx and the bronchioles to come outside through your mouth, or maybe through the nose and all that. So sometimes these mycobacteria get studied onto the mucosa where this material is passing. So you can form what you call laryngeal tuberculosis. This is what you call isolated tuberculosis. Now, sometimes you may have tuberculosis just in one organ, and this may appear in any organ or tissues, and it usually follows a hematogenous spread from the lung. For example, you can get your first infection with tuberculosis, and it goes through the blood system, and it just decides to settle in your kidneys, and you get to call adrenal TB. Or it can settle in the bones, or it can settle in the fallopian tube. Now, when it settles in the bones, a common type of bone TB that you see is what we call Pott's disease. Now, in Pott's disease, here the TB affects the vertebra bones, and someone presents with with a paraspinal swelling, what we call a cold abscess. They are called cold abscesses because they are not tender, they are not hot. Normal abscesses are supposed to be hot, tender, and erythematous. But these ones are not hot, they are not tender. That's why they're called cold abscesses. And sometimes these abscesses can form draining channels that can drain to the abdominal region and the pelvis. So someone may present with a pelvic mass. We can have lymphadenitis, or what you call TB adenitis. So here the TB affects the lymph nodes, and the common lymph nodes we see that are affected with TB are the cervical lymph nodes, posterior cervical lymph nodes. So when they are infected, we call that scrofula. The other form is intestinal tuberculosis, which we can also see. Now, this 2 picture micrograph shows us TB in the apex of the lung. You see this cavitation in the apex. This is secondary TB in the lungs. This is a spleen that shows you these small gray areas which are studded all over the lung. These are consolidations. So this is miliary TB of the what? Of the spleen. Now, the clinical features of TB. How does TB present? Now, these are very important to you because you are the people who are going to be taking medical history when you reach your 3rd year. Medical history. You need to enlist some of these symptoms in people. They have them, but they don't know. For example, someone may present with malaise, or what called general body weakness. Someone comes and telling you, doctor, I've been weak for like the past 3 weeks. I don't know why I'm weak. I can't wake up from bed. They present with anorexia, loss of appetite. They can't eat anything. They don't have an appetite. They present with weight loss. Then remittent evening fevers. Remittent evening fevers. They are called remittent because they come and go. Today you have the fever in the evening, tomorrow you don't have it. You have the fever in the evening, by morning you're fair, you're a bit better. The next day it disappears, it comes back. Drenching night sweats. Now, you guys, the words we attach to these clinical symptoms are very important. Drenching night sweats. Most of us sweat at night, but the sweats are not drenching. They don't make your bed sheets wet. They don't make your pillows wet. So if someone tells you ask if they have TB. Drenching night sweats, pirombisi. It can be TB. So look out for some of these things. Then mucoid sputum. The sputum is initially mucoid, but later it can become purulent. Remember I've told that these cavities, they erode into the blood vessels as they enlarge. They can erode into blood vessels, and then you present with what? Hemoptysis. So that is another sign, another clinical feature, hemoptysis, coughing out of blood. Then pruritic chest pain. Every time someone's breathing, they have chest pain. It might be TB. So please, these are important clinical features that you need to know, all of you. Some of your relatives might be having these things, but because you're not yet there, they keep asking you. They know you're a doctor, they ask you these things and you don't know anything. Look out for these things. It might be TB and you can save a life. So how do we make diagnosis of TB? Now, there are what we call screening methods for TB. These ones can just tell whether someone is infected, but they'll not tell whether someone has an active disease. Now, most of us have been infected with TB. We have our infections in the lungs and they are silent. We don't have any symptoms. But at some point when you get immunosuppressed, you can come up with TB from nowhere, but it has been silent. So we need to have, these are some of the screening tools screening methods that we do to find out whether someone has ever been infected with TB or they haven't. One of them is what we call the Man2 skin test. Man2 skin test, they use a certain component from the bacterial cell wall, what we call the purified protein derivative, PPD. They get that part of the cell wall and they inject it either on your arm, but subcutaneously. And they monitor the reaction over a period of 72 hours, I think, if I remember properly. So if you've ever been infected with TB, your body has antibodies against that purified protein derivative that has been injected under your skin. So those antibodies are going now to react against that PPD. And when they react, you're going to form a lesion on your skin. If that lesion exceeds 10 millimeters in diameter, then they will call that a positive Man2 skin test. And that will mean that you have ever been infected with TB, so you have antibodies against TB. However, you can get false positives and false negatives with this Man2 skin test. For example, most of us are vaccinated against TB. The BCG we get at birth, it contains the vaccine that is against TB. When you are vaccinated against TB with that BCG vaccine, and you are injected with a PPD, you get a false positive because your body you have antibodies against this PPD from the vaccine that you got when you were young. But you can also get false negatives in people whose bodies cannot form antibodies. For example, if someone is immune suppressed, whether due to illness or due to drugs, if you're taking steroids for any reason, if someone has HIV/AIDS, if someone has Hodgkin's lymphoma, if someone has renal failure, if someone has nephrotic syndrome, they are losing their proteins, so they can't form antibodies. So they are going to give you a false negative. Then the other one is chest X-ray. You can screen with the chest X-ray. And here you look for these hilar nodules and the parenchymal lesions. Those are for screening. Chest X-ray is used for screening because those lesions can be due to any pneumonia. It could be bacterial pneumonia, or it could be TB. So they are used for screening. Now, how do you confirm TB? Confirming TB, there are several methods, but the gold standard that we use currently is what we call GeneXpert. GeneXpert is a DNA technique that detects the genetic material of the mycobacterium. So it looks for the DNA, just not the cell, but the DNA of the organism itself. So it's the gold standard that we use currently. And GeneXpert can detect the organism, but it's also able to tell you whether the organism is sensitive to the drugs we give or it's resistant to the common drugs we use, commonly rifampicin. So GeneXpert is very important. When probably you reach third year, you'll come to learn about some of these things, and you'll see the GeneXpert machine. Actually, right now I'm talking to you from the GeneXpert lab, where they do these things from. That's where I'm seated right now. Then the other way is fine needle cytology. You can do finding of the lymph nodes. And here, you look at the morphology of the aspirate. You can identify necrosis. You can identify cells, giant cells. You can identify epithelial histiocytes. So FNA can give a diagnosis. Urine lamb. Lamb is lipoarabinomannan. Lipoarabinomannan is one of the components of the mycobacterial cell wall. So you can use this one to detect for this organism, especially in urine of immune suppressed people. The other way is using a ZN stain. I didn't, but it's very important. ZN. Before the gene expert, ZN, what we call the urination stain, used to be the gold standard, but this has been overtaken by gene expert. So ZN stain is very important. You should also include it in the diagnosis. Cultures can be done, but rarely, because these organisms really, they take long to grant. I mean, we may not have the required environment to culture them, but culture can also be done. So this one gives you a summary of whatever I've talked about from the very beginning. You'll go through it. So after TB, now we look at leprosy, or what we call Hansen's disease. Now, leprosy is another disease that is caused by a mycobacteria. But this time around, the mycobacteria is called Mycobacterium leprae. That mainly affects the skin and the peripheral nerves. Are you together? It's an obligate intracellular organism that is gram-positive and weakly acid-fast. The important features for you. Now, the source of infection and the route of transmission of this Mycobacterium leprae are not well known, but the human respiratory secretions or the soil are likely to be the source of these organisms. And the incubation period for leprosy is about 3 to 5 years. So you may get the infection today, but for you to present with the disease, it can take you up to 5 years. Have leprosy. You've heard about this disease right from the biblical times of Jesus. You've heard of people who had the leprosy right from the biblical times. So it's an ancient disease that has been there for, years. Because even when Jesus came, he found people had leprosy. So it was there even before Jesus. So it's an ancient disease. Right? These days, the disease is quite rare. We rarely see it. So what's the pathogenesis? This Mycobacterium leprae is taken up by the macrophages and disseminates in the blood. It replicates primarily in relatively cool tissues of temperature between 32 to 34 degrees of the skin and extremities. So your ears are they provide a good environment for these organisms to proliferate. The scrotum can be a good environment for these organisms to grow because those are cooler areas of the body. So this leprae secretes no toxins, and its virulence, the virulence factors or the properties are actually a result of the body's response against the bacteria itself. So it doesn't form any toxins, just like tuberculosis. It doesn't form any toxin, but the virulence is based on the properties of its cell wall. The body reacts to the cell wall and then it causes tissue destruction. Basically, the body suffers because of what you call the so-called collateral damage. You've heard of that term, collateral damage, many times. So the body damage due to that collateral damage that happens when the body is fighting the bacteria, the body cells get injured as collateral. So Immunization with BCG confers some bit of protection against leprosy as well. So, how is leprosy classified? So there are two main types of TB, leprosy. What you call the polar types. What you call lepromatous leprosy. This is the type of leprosy that we see in people who have low immunity. So people with low immunity, they tend to present with a mild form of disease. So we call it lepromatous leprosy. The form is mild, but they have a lot of the organisms, but the tissue damage is mild. The other polar type is what we call the tuberculoid leprosy. Now, this one we see it in people who have very high immunity. So, because of the high immunity, their body fights against this mycobacterium, and it's also known as the post-bacillary leprosy. Post means few. So, you're going to see very few bacilli in this type of disease, but you're going to see a lot of tissue damage. So a bit of a paradox. Lepromatous, very many mycobacterial organism, low immunity, less severe disease. In the tuberculoid type, high immunity, very few mycobacterium leprosy organism, very severe tissue damage. So, apart from those two polar forms, there are what we call intermediate types between the two forms. And these are the ones. There's what we call tuberculoid polar, high immunity. Then there's what we call borderline tuberculoid. In borderline tuberculoid, someone has features of both tuberculoid and lepromatous, but there are more features of tuberculoid than lepromatous. So it falls more to the tuberculoid type. So we call that tuberculoid borderline. Then we have to call mid-borderline. In mid-borderline, what we call the dimorphic type, this one, someone has equal features of either polar forms. Then there's what we call borderline lepromatous. Someone has some features of tuberculoid and features of lepromatous features than those of what? Leprosy. And we want these things. So these are the differences between tuberculoid and lepromatous leprosy. Lepromatous leprosy, the skin lesions are symmetrical, they are multiple, they are hypopigmented, they are erythematous, and they form macules and papules or nodules. In tuberculoid, there's an asymmetry. You may find single or very few lesions because of high immunity. The lesions are hypopigmented and they are erythematous macules. Here we see maculopapular and nodules. Here we see macules. These are symmetrical, these are asymmetrical. Here there are very few lesions, here there are multiple. Nerve involvement. So this first skin lesion alone has about three differences between the tuberculoid and lepromatous. Then nerve involvement. In lepromatous, nerve involvement is present, but sensory disturbance is less severe because there's less immunity. But here there is very distinct sensory disturbance because of this high immunity. So the body is overreacting to the organism and causing more nerve damage. Histopathology. In lepromatous leprosy, you are going to see collection of foamy macrophages. All leprosy cells in the dermis separated from the epidermis by a clear zone. In the tuberculoid, you are going to see hard tubercles similar to granulomatous lesions eroding the basal layer of epidermis, and there's no clear zone. These are very important differences. Bacteriology. Lepromatous, the lepra cells are highly positive for lepra bacilli. So you're going to see so many bacilli in lepromatous leprosy, and they're going to be packed like those cigarettes. The way they are packed in the pack, that's how they're going to be packed. But in the tuberculosis, you're going to see very few leprous cells because of the high immunity that fights against these bacteria, and they are killed. So they're going to be very few. Immunity. Lepromatous who have low immunity here have high immunity. Then the lepromin skin test. Now, lepromin skin test is similar to what we call Mantoux skin test in TB. It's the same technique. So in lepromatous leprosy, here it's negative, here it's positive because of the immunity. Morphology, you're going to read about it here. And now, these are the granulomas. Microscopically, the lesions contain large aggregates of lipid-laden macrophages, what called the leprosy cells, often filled with masses of the bacteria. So, you see these collections here. Those are all granulomas. But now the difference between tuberculosis and leprosy is that in leprosy, the granulomas are non-caseating. That is very significant. Granulomas in leprosy are non-caseating. And leprosy commonly affects the skin and the nerves. Those are very key important differences that you must know. Now, this is some gentleman with lepromatous leprosy, with multiple nodules all over the face, maculopapular and nodular lesions all over the face, what we call leonine fasces. Now, they are called leonine, this word, leonine fasces, because they resemble, somehow, it's like a lion's face. That's what they're called, leonine fasces. The face like a lion, lion's face. Then, in B, is someone who has undergone auto amputation because of leprosy. Remember, leprosy affects the nerves. So when the nerves are damaged, you are not going to sense injuries to your body. So you can even knock your toe and you're bleeding, but you can't feel any pain. So because of the nerve damage, these limbs, these toes undergo auto amputation. So they just fall off, they start falling off automatically. Then this is a person with tuberculosis leprosy where there are macules. They are just patches. You don't say they are patches on the face. They can be few or they can be multiple, but they're usually fewer than those you see in lepromatous leprosy. So, diagnosis, acid-fast staining, just like in TB. Then there's what you call the Fit-Farco stain. This is just a modified ZN that can detect this organism. And then there's what you call Gomor methenamine silver stain. This one can also be used, and to detect it, it's going to detect the mycobacterium itself. Then PCR, we can do PCR for this, polymerase chain reaction. So, away from the mycobacterial diseases, now you look at syphilis. Syphilis is a disease caused by a spirochete called Treponema pallidum. It is a sexually transmitted disease or infection. It can be acquired across the placenta, and this usually occurs in pregnant mothers within the second, who have either primary or secondary syphilis. They can transmit this disease to their unborn babies through the placenta. So, Treponema pallidum is a coiled spiral filamentous organism about 10 micrometers long, and it can move actively in fresh preparation. So when you do fresh preparations, for example, someone has a lesion on the penis, you scrape it off, put on the slide, and you view under a microscope. You can see these spirochetes moving. There are other treponema diseases like what you call yaw, pinta, and bijo. These are others, but we shall not focus on those because they are quite rare here. So our focus is going to be on syphilis. So Treponema pallidum has not been actively, has not been cultivated in any culture media, but experimental infections have been demonstrated. So you can experiment an infection, but you cannot culture this organism. And it's very susceptible to destruction by heat, antiseptic, or even cold. Very susceptible. The epidemiology, you're going to read about it. And now, what is important at the modes of transmission? Sexual intercourse, of course, with an infected person. This is going to result in lesions on the glans penis, on the vulva, on the vagina, or on the cervix. Intimate person-to-person contact. So if someone has active lesions on the skin and you have that intimate person-to-person contact, kissing, any contact that's very intimate, very close, you can acquire this organism, this infection. So you're going to form lesions on the lips, on the tongue, on the fingers, anything. They can appear anywhere, whichever side that got into contact with an active lesion. Then transfusion of infected blood, and of course organ transplants without doing the due diligence of what? Screening these people for some of these infectious agents. You can acquire syphilis. Transplacental, maternal fetal transmission causes congenital syphilis. We shall look at congenital syphilis in detail somewhere as we go along. So the pathogenesis, disease, like what we've already seen, it appears due to the body's immune response. Syphilis alone, the treponema alone, you get infected. But because the body is over responding to it, that's why you're going to present with symptoms. But the treponema itself is not going to cause you anything. But the body's immune response is what's going to cause what? To cause the problem. So much of the pathology we see in syphilis is attributed to the ischemia produced by the vascular lesions. So this syphilis tends to cause what you call endarteritis, inflammation of the terminal arteries in the body. So when these arteries get inflamed, they're going to cause a number of course, when they're inflamed, you're going to get a number of end organ damage, because when they're inflamed, you can get stasis, you are going to have edema, you can get a thrombus forming, so you can have blood, you can have ischemia in the terminal organs, the terminal end of these arterioles. So we see proliferative endarteritis affecting small vessels with a surrounding plasma cell-rich infiltrate, which is characteristic of all stages of syphilis. So in histology, when we see an organ with a lot of plasma cells around blood vessels, we shall know that this is actually syphilis, endarteritis. So syphilis has three major clinical stages. There's what we call primary syphilis, secondary syphilis, and tertiary what? Tertiary syphilis. And we're going to look at each of these in detail, the morphology and the clinical symptoms. So primary syphilis, this appears after 2 to 3 weeks after an exposure to the infection. And usually someone forms a single non-tender raised lesion on the genital or extragenital side. So this lesion forms at the site of inoculation. either the lip, the penis, the testis, the vulva, the cervix, and it's painless, it's raised, it's reddened, and it's what we call a chancre, what we call a syphilitic chancre. Initially, the lesion is painless. It appears as a papule, but later ulcerates to form an indurated lesion. And because of, as the lesion undergoes modification or it matures, the organs are going to go to the bloodstream and they are going to visit the lymph nodes. So you are going to present with lymphadenitis. You're going to present with regional lymph nodes. So if the lesion formed at the penis, at the glans penis, you're going to have inguinal lymph nodes forming. If the chancre has formed on the lips, you're going to have cervical lymph nodes. If the chancre is formed on your fingers, you're going to have axillary lymph nodes. If the chancre is formed on your toes, you're going to have inguinal lymph nodes as well. So usually the spirochetes are very plentiful in the chancre. That's why primary syphilis can transmit. If a mother has primary syphilis, she can transmit it to the fetus because there's so many spirochetes. So it tends to spread through the bloodstream to the lymph nodes. And usually this chancre is going to heal spontaneously without even treatment. So you are going to form your chancre, and because it's going to heal without treatment, you are like not, it's painless, and after some time it's going to heal. So you may not go for treatment, but later you may progress to secondary syphilis. So when you get any lesion in your genitals that is ulcerative, non-tender, please go and screen for syphilis. Others, if you just going to heal and you take it like something normal, and later may present with secondary syphilis. Now, this is a lesion of primary syphilis on the scrotum of this guy. You can see it's reddened, it is indurated, right? And plasma cell, a characteristic cell we see in syphilitic endarteritis. Secondary syphilis, so this one tends to appear after months of exposure. So you get your primary chancre and it heals without any treatment. You think it's just something normal. Then 3 months later, you can present with secondary syphilis. And this one is seen in 75% of people with untreated primary syphilis. It presents with painless mucocutaneous lesions and lymphadenopathy. So here the lesions are going to be on the skin, cutaneous, and the mucous membrane, and then lymphadenopathy. These are very characteristic. So skin lesions are going to be seen on the palm, on the soles, and they may either be maculopapular, scaly, or passular. So they may either appear as macules, as papules, they may form scales, or they may form papules. They may contain pus. Those are called papules. And they're going to be on the palm and the sole. Now, areas of the skin that are moist, like the axillary region, the inguinal region, the anogenital region. Someone is going to present with what you call condylomata lata. These are warts, but these are what we see in syphilis. Now, there are what we see in HPV, what we call condyloma acuminata. Those are what you see in HPV. They are called condyloma acuminata. The warts we see in syphilis are called condylomata lata. And these are going to form in the mucocutaneous lesions, in the wet lesion, in the moist regions of the skin, the axilla, the anogenital regions, the inguinal region, the inner thighs. You're going to form these warts, what we call the condylomata lata. And we are going to see how these look like. Then in your mouth or in the pharynx and the genital areas, genital mucous membranes, you are likely to find silvery gray superficial erosions. You're going to see erosions in the mouth or in your vagina or in your oropharynx. You're going to see these lesions, silvery gray in color. Then you may have mild flu, fever-like symptoms, weight loss. And some people, the syphilis can progress the central nervous system and they present with meningitis, visual changes, and hearing disturbance. So after several weeks, then the person enters what we call a latent stage of disease. I've said that there are three major stages, major ones: primary, secondary, tertiary. There's a latent stage, but this is just minor because there's nothing happening there. You have the disease, but it's quiet, it's latent. So antibodies are always positive at secondary, by the time someone enters secondary what? Secondary stage. And this is the most infectious stage of syphilis. Secondary syphilis is highly infective stage, and the spirochetes here, they can be easily seen on any of these mucocutaneous lesions. So right here, we have the appearance, the gross morphology. These first two images shows you the differences between the wart of HPV and that what we see in syphilis. Now, HPV warts are a bit papillary. They are filiform. They are like small finger-like projects. They are velvet, if I can say. Those are how HPV look like. They are velvet, cauliflower-like. And they can form, they can be polypoid. They can have a stalk and a body. Syritic warts, what we call condylomata lata, they are nodular. They form just nodules, nodular masses that are not, they're like elevated nodules, plaques, flat-topped. But those in HPV, they're finger-like, velvet, cauliflower-like. I hope you know that you get the difference. Now, these are the lesions on the palm. They are macular lesions. They are areas of discoloration on the palm. When you see these, please, it might be syphilis. Actually, in medicine, syphilis is the greatest mimicker. It can resemble anything. So, in the mouth, you can see these gray silvery lesions. These are lesions in the mouth. They are gray silvery. You can update them here. That is syphilis. So, after secondary syphilis, you enter the latent stage. After the latent stage, about five years later or more, someone can present with what we call tertiary syphilis. And this one happens in a third of untreated patients. So if 10 people, or if 100 people have syphilis today, they get syphilis today, 75% of those, 75 of them are going to progress to secondary syphilis. The other 25 may not progress. And if those 20 of those 100 who had primary syphilis, a third of them, like maybe let me say 25%, 25%, 25 of them will progress to what? To the tertiary stage after 5 years. So here the lesions are much less infective and the spirochetes are very difficult to demonstrate. And tertiary syphilis has 3 main manifestations. There's what we call cardiovascular syphilis. Now this one we have syphilis affecting the heart and the blood vessels. So there's what we call syphilitic aortitis. Syphilis can affect the aorta. And because of the inflammation in the aorta, it's going to cause weakening of the aortic wall. So someone may present with an aortic aneurysm. And these aneurysms tend to affect the root and the arch of the aorta, where the aorta bends to go down to form the abdominal aorta. At that bend, it's what we call the arch. That is either where it commonly affects. So you can form an aneurysm at that point. And this aneurysm can rupture and you get sudden death. The other thing is that this aneurysm, when it forms, remember it's a dilatation. It can cause insufficiency of the aortic valves. So someone may present with regurgitation of blood back into the left ventricle. And you may present with signs and symptoms of what? Of heart failure or a valvular dysfunction. But the most feared complication is what? Aneurysm formation and subsequent what? Rupture. Then neurosyphilis is another form of tertiary syphilis. So neurosyphilis usually affects the nervous system, like the name says. And it may be either symptomatic or asymptomatic. So in the symptomatic syphilis, in the symptomatic neurosyphilis, we have 3 other subtypes or subclassifications or presentations. Symptomatic neurosyphilis can present with what called meningovascular neurosyphilis. So, like the name says, it affects the meninges and the blood vessels. So, meningovascular. So this one, when you do a spinal tap, a lumbar puncture, you can be able to demonstrate spirochetes in the CSF on wet preparation. Then you can have what we call paretic neurosyphilis. Now, paresis neurosyphilis usually affects the parenchyma. It affects the brain matter itself. So someone presents with the signs and symptoms of like the motor sensory issues. That's why sometimes we call it what it's called the genoparesis of the insane. Some present as if they are mad, right? They have motor and sensory disturbance, cognitive, motor, sensory, and basically every CNS function is disturbed. So we call it genoparesis of the insane because of involvement of the parenchyma of the what? Of the brain. Then there's what we call tabes dorsalis. So tabes dorsalis, this one affects the sensory axon in the spinal cord. So you have sensory loss because of spinal cord involvement. So you lose what we call joint position sense. You don't know where your legs are. You basically, you are moving and you're just knocking things anyhow because you have lost your joint position sense because of spinal cord injury due to the syphilis. Then the asymptomatic neurosyphilis, this one is basically suspected on findings of abnormal CSF, on abnormal CSF findings. Things like decreased glucose, elevated cells in the CSF and increased number of what? Of proteins in the CSF. Then you can think of asymptomatic neurosyphilis. The third type of tertiary syphilis is what we call benign tertiary syphilis. Now this one is characterized by formation of gumas. They are nodular areas of necrosis in bone, skin, and mucous membranes. A guma is a nodular, solitary, localized labral lesion with central necrosis. And secondary involvement can cause pain, tenderness, swelling, and pathological fractures. Now, these are the images showing you a guma right here. A guma is formed in the mouth, in the palate. Is that nodular? That's the center of necrosis, that area of ulceration. Now here, the guma has eaten away the whole nose. It's eaten away the nose. This is what we call tabes dorsalis. The last one here. You've lost joint position sense, and you've lost nervous supply, and now you have deformities forming in the feet. You injure your feet anyhow because you're moving anyhow. You can knock things as if you're not seeing them. So the last part about syphilis is what you call congenital syphilis. This one forms in babies, in fetuses who are exposed to maternal spirochetemia, usually either during primary or secondary syphilis. So you have intrauterine and perinatal death occurring in up to 25% of the cases of congenital syphilis. And it's divided into the infantile type and then the childhood type. The infantile occurs in the first years of life, and the childhood happens later in life. The clinical symptoms are these ones. Snuffles. If you find a baby has just been born today, but they have copious mucopurulent nasal discharge. Like a child is born today, but they have almost pus coming from their nose. Those are what we call snuffles. Mucopurulent nasal discharge. It's a sign and symptom of what? Congenital syphilis. Saddle nose. Syphilis, congenital syphilis affects bone formation, and it causes, because of the gumas, they're going to destroy the bone. So the nasal cartilage is going to be damaged, and the child is going to be born without this nasal cartilage. So they're going to present with a flat nose. That's what called saddle nose. You're going to see the image. Then you can have mucocutaneous lesions of acquired secondary syphilis. So you can have maculopapular lesions on the palm. You can have condylomata lata. You can have salivary gray lesions in the mouth and the genital areas. Name all those whatevers. Then cracks and fissures that occur around the mouth, anus, and the vulva, or what you call raggeds. These are like, most of you know what to call enchacha. You've seen many people saying that when you have fissures in the feet, you have syphilis, sign of syphilis. And many herbalists have made money out of from these things. You can form these fissures on the feet because they're footed. But if you have a child, if you have a neonate that is born today and they have fissures around the mouth, they have cracks around the mouth, the ends of the mouth, at the anal region, at the vulva, please, that is a sign of syphilis, congenital syphilis. Condylomata lata around the anus and femoral genitalia, it may develop early. If a child is born and they have hepatosplenomegaly, sign of syphilis. They are what you call Hutchinson's teeth and what you call Mulberry molars. Now, normal molars should have at least between 3 to 4 cusps. Cusps are those elevations on the top of your molars. They are called cusps. They should be 3 to 4. But in syphilis, you have what you call Mulberry molars. where there are very many small poorly formed cusps on your molars. The Hutchinson teeth are like notched incisors. The either ends of the incisors are notched. Then there are what called submachines. These are other things: 8 nerve deafness, interstitial keratitis, and corneopacities. So these are the things: Hutchinson teeth in A, mulberry molars, submachine, saddle nose. These are typical of congenital what? Syphilis. Diagnosis, you're going to read about it here. So now, the next one is schistosomiasis. This one I'm not going to talk much about it. I just want you to know the different species of schistosoma and what they can cause. Read about it. Read about the life cycle of schistosoma, and then these are the salmonella and typhoid. These you're going to read about. And please make notes about malaria, especially malaria. Read about malaria. Species of malaria parasite, life cycle, simple and complicated malaria, the pathogenesis of those two. Please read about them. Please read about them. And make notes about them. You never know where they can save you. So now I'm going to respond to a few questions if there are any. Otherwise, the presentation is done. Let me listen to a few questions.
Excuse me, doctor.
Yes, please.
My question is on tuberculosis.
Yes.
You said that in primary tuberculosis, we don't have cavities formed.
You don't have what?
Cavities.
Yes, they form in secondary tuberculosis because of
So
the sensitization.
does it mean that we may not have coughing of blood in primary syphilis? No, in primary tuberculosis.
It's less likely going to be there. We don't form it unless there's what we call primary progressive TB. If you get primary progressive TB, it means that the TB that was supposed to be localized is progressing. So if it progresses, it can also erode. But in most cases, it doesn't. But if it's progressive, it can give you hemoptysis. And you can form cavities as someone coughs out those secretions through the alveoli. But they're common. Cavities are commonly seen in secondary TB. Now, the word is commonly seen, but it's not exclusive. It's not exclusive. I'm not saying that exclusively cavities are seen in secondary TB only. No, it's not exclusive secondary TB. They may, but they are more common in secondary TB. But they can as well form in primary TB, but commonly seen in secondary tuberculosis. Have I answered you?
Yes, doctor.
Any other questions? So if there are no other questions, thank you so much. Please read about malaria. Make notes about malaria, the species of malaria parasite, the life cycle, and the pathogens of chronic and simple malaria. It's very important that you know about them. I would actually prefer to have assignments for that handed in form of either a Word document, preferably, including the species of malaria parasite, the epidemiology of malaria, the life cycle of malaria parasite.
Excuse me, sir.
Pathogenesis of simple and complicated malaria, and the clinical presentation of those two types of malaria. Please have that assignment done, and you should hand it in. Today is 18th. Latest should be 30th of this month. I've given you enough time to do this assignment, and you hand it in.
Yes,
In your
Mr.
respective classes, pharmacy and then medicine. Otherwise, if there are no other questions, someone had a hand.
Excuse me, doctor.
Yes, Jimmy.
Maybe I'll request, maybe you could formulate the whole questions, then you send them to the class presidents, then they help give it to the class members.
Okay, I'm going to share with your president, then they will communicate to you.
Thank you.
Thank you. All right, have a good evening.